Okay, well, welcome and good morning, everybody, and it's nice to see some familiar faces from the West Midlands that have made the journey here. So, I haven't got a huge number of slides, and that's deliberate because I think I want to take this slowly, and I think hopefully give time for some questions from the audience. So, as Zorf has introduced, I'm talking about XLH in children and adolescents. So, just to clarify, and as Zorf indicated, the terminology for this condition has moved from X-linked hypophosphatemic rickets to X-linked hypophosphatemia, because this isn't just rickets. So let's just think about some of these terms. So why is it called X-linked? Well, that's because we know that the abnormal gene is carried on an X chromosome, and I'm going to explain in a couple of slides in a minute about the inheritance of this condition. Hypophosphatemic. Now, medics always like long words, but hypophosphatemic basically means low levels of phosphate in the blood. And that's the basic problem in this condition. You've got a low level of phosphate in the blood. And phosphate is a very important component of your bones. Phosphate and calcium combine together to be the vital component. So if you've got a low level of phosphate, that's going to affect the strength of your bones. And rickets only occurs in children because rickets affects just the growth plate, so the end of the long bones. Whereas we know that this process isn't just something that affects children. It also affects the whole of the skeleton. It also affects the teeth, as we will hear about. And when it affects throughout the skeleton, it's known as osteomalacia. And essentially, if you've got osteomalacia or rickets, you have soft bones, which is why in this condition, when children start to walk, that their legs get progressively more bowed, because those bones aren't strong enough to take the weight bearing, and that's why they progressively start to become bow-legged, and then potentially at a later age knock-kneed. This is a family I first got to know about 25 years ago. I actually don't get involved with them anymore, but I used to look after this boy and his cousin. And as you will see, in their parents' generation, there were 3 affected adults. So, mother of this boy, this father who didn't have any, this individual didn't have any children, and this father who went on to have an affected girl. And we know from this condition that, because it's X-linked, that the grandmother must also have been affected. And that's a typical sort of X-linked inheritance. Let's move on. So we know that this gene is carried on the X chromosome. Now we have 23 pairs of chromosomes, but we have 1 pair of what are known as the sex chromosomes. So in a boy, it's 1 X chromosome and a Y chromosome. And in a girl, it's 2 X chromosomes. And the abnormal gene is carried on the X chromosome. So this is trying to explain the inheritance, and I'm sure those of you who have this in the families will be familiar with this. This is what happens if the father has the condition. So he has only 1 X chromosome and a Y chromosome. And on that X chromosome, he's got the abnormal gene, known as the FEX gene, that causes this condition. He has children with this woman who has 2 normal X chromosomes. So when you share out the combinations, he only passes his Y chromosome on to his sons, because boys have an X and a Y. They get their X chromosome from the mother and the Y chromosome from the father. So if you have the condition as a father, your sons will not inherit the condition. Whereas the daughters will have the condition. So the father passes on his X chromosome, and the 1 X chromosome comes from the mother. Because it's an X-linked dominant condition, that X chromosome from the father that carries the abnormal gene is expressed. And that's why all girls born to fathers with this condition will inherit it. So moving on to the opposite scenario, where you've got an affected mother. So she's got 2 X chromosomes, 1 of which carries the abnormal gene, 1 of which X chromosome has a normal gene. So normally you have 2 copies of a gene. So what happens here? So in this situation, it's essentially a 50% chance. So 50% of boys will have the condition, so a 1 in 2 chance if you have a boy that is affected, and a 1 in 2 chance if you have a girl that they're affected, because of this X-linked dominant inheritance. So that's what we know in terms of the genetics of this condition. I'm going to spend just a little time just explaining some of what we've learned over the past 20 years about this condition, and we've learned a huge amount in that time, and I know Raja Padadila is going to talk at the end. He's going to talk about this in a bit more and about potential new treatment options. So what we've learned over the past few years, we've always known that the problem in this condition is a low level of phosphate in the blood, and you have that low level of phosphate in the blood because too much phosphate is going out in the urine. Okay, so your kidneys, which normally hang on to as much phosphate, so they filter your blood and normally hang on to as much phosphate as possible, are leaking excess phosphate in the urine. But it's not a kidney condition, so you can't solve this problem by doing a kidney transplant. So what we've realized and found out over the past 20 years is that this condition is due to a hormone. So a hormone is a chemical messenger that circulates around the body and affects particularly the kidneys to cause them to leak phosphate in the urine. And what we know is there is this sort of link between the bones and the kidneys. There is this sort of signaling mechanism that goes on between the bones and the kidneys. And the abnormality in X-linked hypophosphatemic rickets is this hormone known as FGF23, or fibroblast growth factor 23. So this is produced from bones, and we produce it normally, but in X-linked hypophosphatemic rickets, we're producing too much of FGF23. And when you've got high levels of FGF23, that is being sensed by the kidneys, and that's causing the kidneys to reduce the amount of phosphate that they hang on to, and it increases the amount of phosphate that goes out in the urine. So it reduces what is known as the tubular reabsorption of phosphate. So essentially more phosphate goes out in the urine. What it also does is it affects the production of a form of vitamin D. So this is the long, complex chemical formula, 1,25-dihydroxyvitamin D. And so you have relatively low levels of that. And those are the 2 main defects in this condition. Low levels of phosphate in the blood and a relatively low level of the 1,25-dihydroxyvitamin D, which is why when we treat this condition, we're essentially giving treatment with phosphate and a form of vitamin D. So Raja will come back to this. I've seen some of his slides, and he's got some quite nice diagrams. They're actually like cartoons, better than mine. So remember, FGF23 is the key abnormality. So the other thing we've learned in the past 20 years, and back in 1995, is what the gene is. So the gene, we always knew it was on, we've known for a long time it's on an X chromosome. But in 1995, it was identified. It was this gene known as PHEX. PHEX stands for phosphate regulating hormone with homologies to endopeptidases on the X chromosome. You probably don't want to say that, but PHEX. So X-linked hypophosphatemic rickets due to an abnormality, a genetic change, what we call a mutation in this gene. And that causes these high levels of FGF23 in the blood, which causes the kidneys to leak excess phosphate. How common is it? We know it occurs with a frequency of about 1 in 20,000 people. On the whole, males, boys, tend to be more severely affected because they only carry 1 copy of that X chromosome. Whereas women will have 1 abnormal copy of the gene and 1 normal copy. So on the whole, boys tend to be more severely affected, although, as I'm sure as Zulf will agree, we've also seen girls that can also have quite severe problems. We know that dental pulp abscesses can be a manifestation due to defects in the dentine, and we've got a dentist here who's going to speak to us later on and explain that. And we know also that this problem doesn't go away in adulthood, and one of the significant problems in adults is you get calcification of tendons and ligaments and osteoarthritis, particularly in the hips and the knees. So how does it come to us? So how does a child with X-linked hypophosphatemic rickets come to somebody like myself? This is from the XLH network website. These are two twin girls at the age of 2, one of whom you can see has got bowed legs and is also shorter than her sister. So she's got X-linked hypophosphatemic rickets, her twin sister is normal. So some individuals will come to us because there's a known family history. So families have this condition, they know that there's a high chance that they may have affected children, so hopefully they come to see us relatively early, hopefully within the first 6 months of life, and often we can make a diagnosis and get the child on treatment by 6 months of age. And that's important in terms of the overall outcomes, being able to start a child on treatment early. But if there isn't a family history, so they say this is a new genetic change in a child, they often come to us with bowed legs. So when a child starts to walk from about the age of 13 months onwards, children will have bowed legs naturally at that age, but what happens is they get progressively more bowed. So instead of the bowing getting better as the child gets older, the legs start to get progressively more bowed and characteristically also develop this sort of waddling gait that you'll be familiar with. If it comes along at a slightly later age, beyond about the age of 2 to 3 years of age, and normally it will come along earlier with bowed legs, if it comes along later, the child will tend to come with knock knees rather than bowed legs. An alternative presentation which I've seen is the child gets referred through to a growth clinic because they're short, and somebody does some investigations and finds there's a low phosphate level in the blood. Another presentation that I've seen is coming from dentists, where a child has been referred to the dental hospital because of recurrent dental abscesses. The dentists are aware of this condition, have thought about it, and they have also checked the bloods and found a low phosphate. So this is a dental abscess. So those of you who've had children who've affected will know that they tend to occur on the gums. And these are the sort of x-rays that you may see, and I've got a larger variety in a minute. So this child has clearly got quite bowed legs. And at the ends of the bones, they're very irregular, rather than being a sharp line. So when we see a child with rickets, and we're suspecting X-linked hypophosphatemic rickets, what kind of investigations do we do? So we do blood tests, and in the blood we find a low level of phosphate in the blood. We usually find a raised level of this chemical called alkaline phosphatase, which is an important enzyme in mineralizing your bones. And if we measure vitamin D, because low vitamin D levels can also cause rickets, vitamin D levels are usually normal in this condition. One very important message, and I've seen situations where there has been a delay in diagnosis, is that the phosphate level in the child should be compared with a reference range for children and not for adults. Because the reference range for adults is lower, it's about 0.85 to 1.35, whereas so if a child presents and comes along with a phosphate level of 1, and somebody compares that to an adult normal range in their laboratory, they sort of think, oh, that's normal. But in fact, the reference range for a child is higher, and a level of plasma phosphate level of 1 is too low in a child of 1 to 2 years of age. So that's an important thing. We measure urine, and we find excess phosphate in the urine, and the calcium level in the urine is normal. And clearly we would do x-rays, and what you get is this irregularity. This is the bottom of the femur, and you've got this very irregular appearance of the metaphysis. So just to give you an example, so this was a 2.5-year-old South Asian girl who came to me a few years ago. She had developed progressive bowing of legs from the age of a year. She'd been to see an orthopedic surgeon who diagnosed rickets. she was referred to a local paediatrician who, because she was a South Asian child, thought this is probably vitamin D deficiency rickets and treated the child with vitamin D, but she didn't get any better. Her blood results didn't get any better, the x-rays didn't get any better, and then she got referred to me. There was no family history. By that time, her height had dropped down to the lower part of the normal range. She had quite significant bowing of her legs, so she had 10.5 centimetres between her knees. And I measured her blood phosphate, and it was low, 0.62. And as I said, normal range for that sort of age is probably going to be down to about 1.2 or 1 at the lowest. So that's clearly very... She had a raised level of chemical alkaline phosphatase. She had a normal vitamin D. She had also been treated with vitamin D, and her urine showed this characteristic of excess phosphate. So I thought she had X-linked hypophosphatemic rickets. Subsequently, I've done genetic testing, and yes, she does have X-linked hypophosphatemic rickets. So what are we doing when we're trying to treat this condition? Why are we doing it? The reasons are, one, we're trying to prevent progressive bone deformity, and therefore trying to prevent the need for that child to have orthopedic surgery. We're trying to have as much normal growth as possible, and also to have normal activity of that child so they can participate in all things that their friends are doing. But also balanced against that, we're also trying to avoid complications. And we know that with the treatment we currently have available, the phosphate and the vitamin D treatment, that there are potential complications. So the treatment currently, and this has been treatment that's been in existence for about 35 years, is a combination of phosphate supplements with either calcitriol or 1-alpha. In the UK and in Europe, we tend to use 1-alpha, whereas in the United States, they would use this drug calcitriol. The phosphate, I'm sure you're familiar with if you've got affected children, needs to be given often. I tend to give it 4 times a day, occasionally 5 times a day. I find it very difficult to try and push it up to 6 times a day, particularly in young children who sleep for long hours overnight. And these are the sort of doses I would start on, and then once hopefully you've got the rickets healed, you reduce the dose, or the child can grow into that dose. So you have a maintenance dose. These are the different preparations. Many of you will be familiar with phosphate sandos, the effervescent preparation that dissolves. Some individuals may be on the K-phos neutral capsules, which have to be imported from the United States. And in a very young child, you occasionally might use something called dual solution. As I say, in the UK, we tend to use 1-alpha as the vitamin D product. Comes in drops. I'm tending to move my patients over from, instead of trying to count 23 drops or something, I'm moving them over to measuring it in a 1 ml syringe. So we're just saying that's equivalent to so much mils, you draw it up out of the bottle. Because I think if you're trying to count a large number of drops, it's not surprising that you can miscount, or and they come out through the dropper quite fast as well. But if in an older child, if you can move them onto capsules, that's quite useful. So you've got different strengths of the capsules. So what do we do in terms of monitoring? You'll be familiar with this. Child comes to clinic. We're doing blood tests. It's rare that you come to clinic and don't have a blood test, unfortunately, in this condition. What are we measuring? We're measuring the calcium level in the blood. We're measuring the phosphate level. We're measuring that enzyme, alkaline phosphatase. We're checking kidney function. I always like to keep an eye on the kidney function with the creatinine. And we're measuring this other hormone that I haven't mentioned so far, called parathyroid hormone. The parathyroid hormone is produced from a set of glands, 4 glands in your neck, actually on the back of the thyroid, which is why they're called parathyroid. And once you start to give phosphate in this condition, the parathyroid hormone levels usually go up. So you need to keep an eye on the parathyroid hormone level. We usually get urine samples, or certainly at least once a year I like to get a urine sample to make sure there's not excess calcium in the urine. So we usually get a spot urine and compare it to the amount of creatinine in the urine. I think it's worth doing the x-rays every 1 to 2 years, particularly to see there's evidence of healing. And ultrasound scans. So usually I do this every 2 years, and we're looking for deposits of calcium in the kidneys, what is known as nephrocalcinosis. But a very important marker of how you're getting on is how well is that child growing, what is the shape of their legs. So measuring the legs, measuring the distance either between the ankles or the knees, and seeing that it's improving is a good marker. And as I've indicated here, when a child is growing more rapidly, so particularly in the first couple of years of life and around puberty, you need to see them more often, sort of 3 to 4 months. Beyond that age, in sort of mid-childhood, often I would see them 6 monthly. And we're trying to keep the balance between the phosphate and the 1-alpha doses. So what do we, when we're looking at the blood results, what are we doing? So if you get an increased level of parathyroid hormone, which, as I say, is quite common once you start to give phosphate, you either treat it by putting up the 1-alpha dose or actually reducing the phosphate dose. If the calcium level is too high, you would drop back on the 1-alpha. If you've got a high calcium and a high parathyroid hormone level, which is thankfully an uncommon condition, you can get what is known as tertiary hyperparathyroidism. So this is where one of those parathyroid glands has been producing too much parathyroid hormone and just becomes independent. It just starts producing it and doesn't switch off even if the plasma calcium is high. The phosphate level in the blood is not a good guide, and you should certainly not try and aim to normalize that blood phosphate, because you'll end up giving too much phosphate and running into complications. So we recognize that when the child comes to clinic, they may have had a phosphate dose in the morning before they come to clinic. By the time they come to clinic, it's mid-morning, and the phosphate level will be low in the blood, but I don't try and push the dose up, because I recognize it does go up and down depending on when they've last had treatment. The alkaline phosphatase level is a guide, but it's not very sensitive. And as I said before, the rate of growth and the shape of the legs are very important markers. Now, we know how do children respond to treatment. We know there's a spectrum of severity. So you can have some children who are relatively easy to treat, who require relatively small doses, who respond extremely well. And then there are others that are much more difficult. So that's essentially what I'm saying there. We know that the long-term outcome in terms of growth is better if a child can be diagnosed and started on treatment under the age of 2 years. But unfortunately, that can sometimes be a problem if there's no family history and the child comes along at the age of 3 or 4 years. We know that compliance with treatment will affect response. And we also know that once you get into the teenage years, that compliance can be a problem, and particularly that lunchtime phosphate dose is often the one that gets missed. And in that scenario, I usually say, well, you can actually make it up at home. You can put it in a bottle of water before you go to school, make it up, and then you just drink it at lunchtime. So I always like to show you my good outcomes. So this is a lad I treated from the age of 6 months. He was, in fact, in that family that I showed you right at the beginning. He was treated from 6 months of age. He grew very well. He actually ended up near to the 50th centile for his height. And he had very straight legs. He didn't require orthopedic surgery. But there are potential problems. One of the problems you'll be familiar with when your child first starts on phosphate is that they can get a bit loose, they can get diarrhea, they can get abdominal pain, and usually the best way to do that is to reduce the amount of phosphate and gradually build it up again. There are potential problems if the child comes to you beyond the age of about 2 years and the height has already dropped below the normal range. It's often very difficult for them to catch up back into the normal range. You can have persistent leg deformity requiring orthopedic surgery, and there is this problem of having to take medication 4 to 5 times a day. And as I've referred to, this thankfully relatively rare complication of the autonomous or tertiary hyperparathyroidism, where one parathyroid gland just takes over and starts producing too much parathyroid, and essentially that has to be treated by an operation to remove that parathyroid gland. Nephrocalcinosis is the deposition of calcium in the kidneys. There's an example of that. It's relatively common. We know it's an effective treatment. Thankfully, it doesn't seem to impair kidney function in the long term, but we do like to keep an eye on it. We don't like it to progress in terms of the amount of calcium And occasionally, you can get a high level of calcium in the blood, and that can also affect the kidney function. And that certainly happened to me 2 or 3 times. A few years ago, for a meeting, we actually looked at our cases, so 24 cases between the ages of 1.5 to 16, and we looked at the complications. So craniosynostosis is where you get premature fusion of some of the sutures in the skull, and you can end up with an abnormal head shape, which may require surgery. Now, that's not a complication of treatment, that's a complication of the underlying condition. So you can see we had 3 cases, one of whom required surgery to correct that. This tertiary hyperparathyroidism requiring removal of a parathyroid gland was in 2 cases. 5 children needed orthopedic surgery. Commented deposition of calcium in the kidneys was relatively common, so nearly half of them had it. And one had this Chiari-type malformation. This is where the base of the brain was just going down below the base of the skull. That was in one case. We know that there's an increased chance of that in this condition. And relatively common, again, dental abscesses. Just going back to growth. So as I said earlier on, if you can make the diagnosis at an earlier stage, you're more likely to preserve that child's growth potential. So I'll try and explain this slide to you. So this is height, but this is represented as what is known as a standard deviation score, the normal range. So the normal range would be between -2 and +2. In the grey bars, you've got children with X-linked hypophosphatemic rickets who are diagnosed under 1 year of age. And so you can see their height is in the normal range. After the first year of treatment, after 9 years, and at adult height, they've tended to stay within the normal range. Whereas the white bars are children who are diagnosed beyond 1 year of age. And you can see already by that condition, many of them are slipping down below, certainly below average, and some below the bottom of the normal range. And you can see they never recovered that lost height potential. So it talks about the importance of early diagnosis in getting a good long-term growth outcome. Orthopedic surgery, I know we've got an orthopedic surgeon who's going to talk in detail. On the whole, doesn't tend to be performed under the age of 6 years because hopefully with good medical treatment and healing of the rickets, the abnormal shape of the legs will improve. It used to require quite major surgery where you had to divide the bones, what is known as an osteotomy, to reshape the legs. But it's now become a lot easier with this technique that I find difficult to pronounce, epiphysiodesis, or what the orthopedic surgeons called 8 plates, because if you look at these sideways on, they look like a figure 8. And essentially, you're putting what look like little staples across the growth plate. And depending on whether you've got bow legs or not knees, you put them in, leave them in for 12 to 18 months as the child grows, and they're only effective as the child's growing, and you get this very nice correction of the deformity. And I think they've made a huge difference to the orthopedic management in this condition. So I'm just finishing off. So there's been a few milestones in XLH over the years. So it was first described in 1937. And at that time, it was described as vitamin D resistant rickets because people recognized that if you give vitamin D, they didn't respond. It's about 1980 that the combination of phosphate supplements and calcitriol was established as the most effective method of treatment. So, as I say, we've had this for about 35 years. 1995, the FEX gene was identified. 2001, people recognized in this condition you had high levels of this hormone FGF23. And as Raja will come on to explain, from 2014 onwards, this led to the potential new way of treating this condition by giving an antibody to that hormone of FGF23. So just to leave you again, and as both of the support groups have been mentioned so far, so the XLH network, they have an excellent website that I would recommend, and I often recommend to my patients, and obviously Climb as an umbrella organisation within the UK. These are the same 2 girls that I showed you earlier on. You remember they were 2 years of age when the younger girl was diagnosed. They're now 5 years of age. So this girl has now got her legs are much straighter, but she's still shorter than her twin sister. Thank you very much. I'm happy to answer questions.
Nick, thank you very much for that excellent overview of X-linked hyperphosphatemia in pediatric and adolescents. We've got plenty of time for questions. So questions from audience, please.
Sorry, my name's Hannah. Just a follow-up question. We were talking earlier about the initial part where you have high phosphate in the blood and alpha phosphate and all that, and D125 is generally low.
Yeah.
In my daughter, at the beginning it was quite high, and it kind of stays rather than being low. I've not seen it low. So is that...
Yeah, just to...
Could you repeat the question so that we can...
Yeah, okay. So I think the question was in terms of diagnosis, and it was your daughter. When she was diagnosed, she had relatively high levels of the 125 dihydroxyvitamin D in her blood, which, from what you're saying, delayed the diagnosis for a while. Is that right? No. Okay. Yeah, so just to clarify, if you measure 125 dihydroxyvitamin D in this condition before you give any treatment, the level is often within the normal range. But we recognise that that's abnormal, because if you've got a low phosphate, what should happen is your body should produce high levels of 125 dihydroxyvitamin D. So if you've got a level within the normal range and you've got a low phosphate, that's an abnormal response to that low phosphate. So you can still have a 125 within the normal range.
I think the other issue is the reference values, the normal values for 125. And I think that the laboratory that went to had, in my opinion, slightly unusual normal values for 125 levels. But a measurement of 125, which I know is done quite routinely in United Arab Emirates, is something that we don't do as such. We might do at a start, but do you routinely measure 125?
Not as part of monitoring on treatment, no.
Yeah.
But partly because if you're giving 1 alpha, we know that gets converted in the body to 125. So you're effectively just measuring your 1 alpha.
Any other questions? Oh, there's a question there.
I've got a microphone. Just... Sorry.
I don't know.
Thank you. I'm Lucy, mom of a boy with XL. My question is, can you explain the mutation for those children who have XL for simultaneous? They don't have, it's not inherited. Is anything maybe researched to help the parent who it might happen to them, they can take to the doctor early as possible before 2? Because mine was diagnosed before nearly 3 years. So can anything be done to that?
Okay, so the question was in relation to the lady clearly has the child has got XLH, but there's no family history, and so he's developed it as a new event. So we recognised in many genetic conditions that they can occur by chance. So a very well-known condition called achondroplasia, which is a form of skeletal dysplasia with individuals who are very short. We know that in many of those, it occurs as a new event. So you can get this new genetic change that occurs without a family history. So we know that it can happen in a lot of genetic conditions. But the problem is, as you've alluded to, without a family history, it can sometimes mean that there's a delay before somebody makes the diagnosis in that child. And so how do we raise recognition? Well, I think by making people like GPs and health visitors and orthopedic surgeons who ultimately see these children think about the possibility of rickets, particularly in a child who's got progressive bowing of their legs. So I think particularly GPs and health visitors are the ones where we need to raise awareness.
There's a question there. Sorry. The microphone.
Hi, James Bates. I have 3 children with
XLH, 2 boys and a girl. If my 2 boys have boys in the future, they won't have the XLN. Is that then wiped out from their line? Or is there a possibility that it will come back?
No. So if your boys have sons, they will not be affected. They will not carry the abnormal gene, and their subsequent children will not have XLH. No.
Hello, my name's Lorraine Croger. I've got 2 children, a boy and a girl, who have a version, I think, of XLH, but where it differs is they don't have rickets, they don't have vitamin D deficiency, and they haven't had any dental symptoms. But what I wanted to know was, in terms of genetics, whether it will, what you mentioned earlier about the male passing it on to the daughter and the female having a 50-50 chance of the children, would that apply to my children?
If they've had genetic, so this is again a question about inheritance. So, have they had genetic testing that's shown they've got an abnormality in the FEX gene?
They've got a gene mutation, yeah, but which affects the tube in the kidney, but they're not affected by rickets.
Okay, that's interesting, but it sounds like they've got a milder form. But if they've got the X-linked form, it should still apply what I was explaining. So right. The boy will not have affected sons, but will have affected daughters.
Yeah.
And your daughter, if she has the X-link, will have a 50-50 chance of having a boy or a girl who has the condition.
Right. Because I mean, Professor McGill will probably better answer their condition better than me, but as far as I'm aware, it's not as straightforward as the XLH condition. It is slightly different.
I think the important thing to mention is that XLH is one of the conditions which causes hypophosphatemic rickets, and there are other spelling mistakes or mutations which also cause hypophosphatemic rickets. And the point that you raise is a very important one. If it is caused by a FEX mutation, then what Professor Shaw has said does pertain. But there are other mutations which are inherited by a sort of a very different mechanism.
Yeah.
And that actually brings me back to a very important issue which came to my mind, Nick, when I saw one of my patients who is now 22 years old and is sitting at the back of the, sitting in the audience. Now, she was diagnosed at the time when we didn't have FEX mutations. And in fact, she had what I would describe a fairly relatively straightforward course. And I just now wonder whether we should be testing all these patients, because she could easily have autosomal dominant form of the disease, because it has totally different inheritance.
It does. So my practice until relatively recently has been not to do genetic testing early on, and I've tended to do it when the child is in their teenage years and I'm thinking of moving them on to my adult colleagues, because I think it is important at that age for the family and the individual who is affected to know what their chances are of having children. Having said that, my practice has changed in that I'm now starting to do genetics at an earlier age, and that's because I'm aware of the potential of a different form of treatment for those that have the X-linked form of this condition. And that's why I'm tending to do genetic testing at an earlier stage. So if new treatment possibilities come along, or participation in clinical trials, and we have patients here who are in the clinical trials, they have to have the X-linked form of the condition. So I'm tending to do it at an early stage now.
So we have Professor Selby in the audience, who will be the next speaker. So Peter, do you sort of do genetic testing in the patients that are transitioned to you? Obviously, it's important from genetic counselling and.
I suppose I take a fairly similar line to Nick, and I tend to, if it's absolutely clear and you've got a definite X-linked family history, I don't do genetic testing. If we're not sure, I tend to refer them up for genetic testing at the time when they're beginning to think about having a family. So it's perhaps a little bit further down the stream from Nick, but it's the same sort of idea. If it's going to make a difference, we'll do it. If it's not going to make a difference, if the genetics is already clear, perhaps someone in the family's been tested and the inheritance is known, then there's no point doing it.
Thank you very much for clarifying that very important issue. We got another question at the end? Sorry. We need a microphone.
Victoria Kennedy. I've got identical twin boys. We have our genetic testing done, and you might have a microphone hijacked in a minute. I just wondered, in terms of have you had any cases for identical twins in terms of the condition, in terms of the way it's sort of manifesting itself? So for the example, the boys, like I had, obviously I've passed it on to them, I had X-shaped legs. And I just wondered, because you were talking in your presentation about children or toddlers in particular having bow-shaped legs. Is that sort of a given, or can it change? Does that depend upon the individual, or does it sort of change as they grow up?
So whether you present with bowed legs or knock knees, what you called X legs, depends on when the rickets really starts to take hold. So we know that in the first couple of years of life, children naturally have a bowing of the legs. So if you have a condition like rickets at that age, the bowing will get worse. Whereas beyond about the age of 2 years, there's a tendency for your legs in all children to move slightly to a more knock-knee position. So if rickets comes on beyond about the 2 years of age, you will exaggerate that knock-knee position. So it depends on the age at which the rickets starts to become active. In most cases of XLH, it's usually early on, and that's why we tend to see bowed legs as more often than knock knees.
Thank you.
Any other questions? Microphone. Sorry.
Thank you. Hi, I'm Soraya, and my daughter has XLH. Well, we think she may have XLH, and she's age 7 now. Unfortunately, she had a very late diagnosis. So with early diagnosis being so critical, and having a son age 3, is it not possible to have the checks done automatically, let's say at the GP? Because my GP is telling me that if there are no symptoms, they wouldn't investigate, but I'm not quite sure, and I'm always second-guessing myself as looking at his legs and worrying and wondering. So,
Okay, so your daughter is 7, and she's almost certainly got X-linked hypophosphatemic rickets.
So she's got X-linked. She's got hyperphosphatemia. She's got the rickets, but the mutation's negative.
Okay.
So.
Right. So occasionally you can have, sometimes you don't get the gene abnormality, but it sounds as though there's no family history.
no, not that we know of. No.
And therefore the chances of you having another affected child is very low indeed. Right. And you say your son is about 3?
He's 3, and his knees do look a bit close together, but then I'm wondering if I'm becoming a bit paranoid as well.
So next time you take your daughter to see Professor McGall, you take your son along as well, and he can just have a quick look at it.
I think it's very easy to do the blood test and the urine test. Do you want to just want to talk about your experience, how difficult it was to make the diagnosis? I know it was, the delay was not in the United Kingdom, it was in another country. Do you want to just talk a little bit about that?
We took our daughter when she was a toddler because we noticed the bowed legs, and
you want to mention where you were?
We were living in Qatar. And we took her to a prominent paediatric doctor, and he thought it was normal and bowed legs can happen at that age and not to worry. And then later we were unhappy about the fact that it was getting worse. She was tested, she had low vitamin D, so they gave her vitamin D and just assumed it was a case of rickets. And we were still unhappy with the fact that it was worsening and while she was on the vitamin D. And for years we took her to different orthopaedic surgeons, different specialists, other paediatricians, and they never diagnosed anything to do with phosphate. And then we came here and the GP did the same blood tests and found vitamin D low and reconfirmed that same diagnosis, and we still were not happy. So unfortunately, she was 6 by the time we met Professor McGall and got a clear understanding.
And she had a lot of dental abscesses as well.
Yeah, but we didn't put 2 and 2 together. We didn't know that a condition could affect those.
It just illustrates that the diagnosis can sometimes be delayed, and as Professor Shaw mentioned, that vitamin D deficiency rickets is more common, and therefore children are often treated as possible vitamin D deficiency rickets. But the key is, as in the case that Professor Shaw mentioned, when there is no improvement, then it should cause the physicians to think about, could this be something else? And there are, besides hyperphosphatemic rickets, there are many other causes, which can cause rickets in children. Okay. Sorry.
Thank you. Glad we met Professor McGall, however.
We got another question there, sorry.
Kind of request. With the NHS, the things are going now, and the doctor said that, the professor said we have to see the GP and health visitor. Is that possible? You know this condition, can give the GP at least idea of this condition or educate them a little bit? Because I live in a rural area, nobody knows about the condition, and I did struggle a little bit until I got referred. It was quite a little bit of fight, and those is 5 years ago. Things are getting really bad in the chest now, and it's very difficult to get a GP appointment. It's very difficult to see health visitor. Is that possible? At least someone like you educate the GP. When they see that condition, they can refer straight away instead of delaying. Someone like me, which is simultaneous, you can avoid those kind of things like that.
Yeah, no, you're absolutely right. It's important that we educate people in primary care, particularly GPs and health visitors. I know in Manchester they run some very successful training days which have attracted people like GPs along. And I think you're right, we need to have similar sort of events elsewhere in the country to raise awareness of this sort of problem.
Where I live, they don't know anything about this condition. Everybody's surprised.
Okay. If there are no further questions.
There's one question
Oh,
here.
sorry, there is one. Sorry, do apologize.
It's carried on the X. The
Yeah.
X-linked.
Yeah.
So why can't you test it from the Y and then the woman's X and create a baby that way?
So you're talking about genetic, so changing genetic material, genetic engineering. Yeah, I've not encountered that being attempted in this condition. Certainly, genetic engineering is something that's been considered in some other conditions, but it's never been, as far as I'm aware of, thought about in XLH. I think potentially with new treatment options becoming available, it may be an easier condition to manage in the future.
Okay, we should move on now. There will be time to meet the experts during break times, etc. Nick, thank you very much for that excellent talk.